Well, thank you for attending tonight's panel. We are very excited on behalf of SEPA to have this wonderful panel of experts that are going to speak to us about all of the intricacies of exercise oncology. Before I introduce our panel, though, I am going to make a quick plug, and I'm just going to share a slide with everyone. If you're looking for something fun to do in February, and you're already planning things out, I'm going to encourage everyone to sign up and attend our annual virtual conference. So this will take place on February 7th, 2026. We have another stellar line of keynote speakers and other presenters for that day. So go ahead and mark your calendars for that. All right, now that that's done, let me go ahead and introduce our panel. So I'm going to just go left to right on my screen. So first we have Sadie Engelken, who is joining us. Next we have Michael Lazio, Karen Wonders, and then Mary Van Holcomb, unfortunately is sick today, so she is not able to make it, but thankfully we have a last minute stand-in. So welcoming Ashley Sison, who is joining us tonight as well and is going to be sharing her expertise. So I'm very excited to have you guys here. Thank you again for taking some time out of your day to come talk to us about this. So starting off, what I'm going to have each of you guys do is just provide a quick introduction. So why don't we start with, let's start with Karen, and just tell us your current role, how you got into the field, and any specialized training or credentials.
Sure. So hi, I'm Karen Wonders. My background is, like a lot of the people on this call, from the University of Northern Colorado, is where I got my PhD. Graduated back in 2006, and I work at Wright State University. I'm a professor there and the program director of exercise science. And then I also am the founder and CEO of Maple Tree Cancer Alliance, which is an organization that provides exercise training to patients as they go through cancer treatment. So in terms of credentials, special credentials that I hold, I do have a cancer certification from UNC from a very, very long time ago. And, you know, that was kind of my primary, I guess, certification or endorsement that I had getting into this field. And then I've just done continuing education and, you know, my own work and research since then.
Great, thank you, Karen. Michael, I'll have you go next.
All right. So again, my name is Michael Lazio. I'm the clinical coordinator of University of Northern Colorado Cancer Rehabilitation Institute. So kind of where back in the day where Karen was at, that's what the program I'm running now. So some specialized certifications. I'm ACSM exercise physiologist, as well as a clinical cancer exercise specialist through that same certification at our clinic as well. And then I've been involved or with cancer rehabilitation since 2011, and ever since then kind of stuck to this career, and was able to resurrect some other programs in the Denver metro area in Colorado called Cancer Fit, and then was able to come back and take this position currently since 2017. I also lecture and educate on our clinical cancer exercise specialist workshops, as well as teach the exercise oncology course, and as well as our practicum courses here at the university.
Excuse me. Thank you, Michael. Ashley, why don't you go next?
All right. Hello, everyone. My name is Ashley Sison. I'm currently the clinical exercise physiologist at Rush MD Anderson Cancer Center in Chicago. How I got in the field, I started at the University of Northern Colorado Cancer Rehab Institute, where I interned with Mr. Lazio here. Specialized training, I got my clinical cancer exercise specialist cert from UNC CRI. After that, I did get my ACSM clinical exercise physiologist certification, and then went on to get my doctoral in clinical exercise physiology from the University of Northern Colorado Cancer Rehab Institute. I started a program at Rush now, where I started as an exercise program for survivorship, cancer survivorship, and it has evolved into prehab and during treatment as well.
Great. Thank you, Ashley. All right, last but not least, Sadie, let's have you tell us about yourself.
Yeah, so Sadie Engelken, my current role, my position is exercise physiologist within a cardiac and pulmonary rehab, CHI Memorial in Chattanooga, Tennessee. But I came here with the purpose of starting an exercise oncology program. So that's why I'm part of the panel today. How I got into the field, I also started at UNC. So I did my capstone for my undergrad degree at UNC, became a certified clinical cancer exercise specialist there. So that was my first specialized credential. I went on to get my master's and studied under Dr. Jessica Brown of the PHASE program and Dr. Daniel Shackelford of the University of Northern Colorado treadmill protocol. So I did my master's under them, which helped me kind of get some additional training in the field. I've worked at several medically integrated gyms. I worked in Kansas City for Cancer Wellness for Life with Sammy Mansfield, doing kind of the consultation model there prior to coming to my current role. I did go on to get my ACSM clinical exercise physiologist certification. And now that I'm going to be training some staff, I took ACSM's new cancer exercise specialist course, which is now a certificate instead of a certification. But those are kind of the things that helped me be in this role.
Great, thank you. So common roots, but we also have kind of a widespread in terms of where people ended up, which I think is great. So next we're going to move into some program descriptions. So I'm just going to remind everyone who's watching, if you have questions, feel free to submit them into the chat as they come to you. And we will have time for a lot of Q&A and hopefully some good conversation once all of our panelists are done explaining just giving us an overview of what their programs are like. So just a refresher for our panelists, taking a few minutes, it can be a little bit longer than your introduction, talking about your program. So the description and history of it, we got a little bit of that from some of you already. The type of programming and services that you provide, and if there's any funding that you seek out that helps support your program. So I'm just going to choose someone random. Let's start with Michael. That'd be great.
All right, thank you, Taylor. So I have to start back almost 30 years ago. Dr. Carol Schneider was the founder of then known as the Rocky Mountain Cancer Rehab Institute, which is we are now called the UNC Cancer Rehab Institute. And I had the pleasure of knowing Dr. Schneider. She was my advisor. I always joke that told me I was doing my master's, so I was able to get my master's here at UNC as well. And then during that time, unfortunately, she had a recurrence of cancer and passed. But I was so fortunate to be, in the presence of her, just to be knowing what her program and her thought and her belief and passion was for this field. So it really invigorated me to want to do more and really encompass that. But for our program, we focus on 3 pillars, one being education, not only for our students, but professionals in the field. Obviously service for our community and our patients and our survivors. And third is going to be research. So we are a research institute, and that's something we pride ourselves on, not only just in a human model, but also in the animal model as well. For our program currently, we're seeing anywhere from 75 and even up to 90 patients a day. This is typically ran through a one-on-one supervised exercise intervention. We also as well have a phase model. Dr. Jessica Brown was a big proponent on this, and what we essentially do in our first initial phases, we have that one-on-one component with our patients, and as they graduate to a phase 4 perspective, then we'll have more of like a group exercise class, an open gym, or some modified group sessions, what you would normally probably see in a hospital or rehab setting where we have one specialist or intern working with a couple patients at that time. So for our program, just to remind myself of some of those questions, Taylor, is for funding. So we're a nonprofit. We solely are funded by grants and donations and fundraising. So if anyone would like to ever donate to our facility, we'd be more than grateful and very appreciative. And we do have a pay out of pocket model currently for our patients, but we try to keep that as low as possible. Currently, right now, it's $100 a month, and not including the initial assessment or reassessment, but that breaks down to 3 days a week. So Monday, Wednesday, Fridays when we see our patients, and that's $8.33 per session. So I don't know anywhere in the world that would, charge that. But that's also helped out with some of that component of having the patients buy in and really adhere to the program, and our adherence has been up since we've kind of implemented that. And of course, obviously with cancer being a financial burden, we have a sliding scale and scholarships for our patients as well. I believe that's all your questions, but let me know if you have any. I can go a little bit further in detail.
Yeah, no, that was great. Thank you so much. I think you covered everything. I'm sure there are going to be a lot of follow-up questions. I took some good notes, so thank you. All right, Sadie, why don't you go next?
Yeah, so as I mentioned, I am currently located in a cardiac rehab space. So we utilize the gym space that is part of our phase 3 maintenance model to train our cancer patients. So that's our outpatient component of the program. We do an intake process similar to UNC, treadmill tests, exercise prescription using the phase model. One challenge we do have in being in the hospital space, it is very hard to do one-on-one for every session when you're a team of 1 or maybe 2 people in the hospital. And our job as a cancer exercise specialist is not a hospital job yet. So my job doesn't exist. We're building it as we go, with having only been there since 2023. And so kind of the model that we have started to use is, I call it semi-independent exercise. I target my patients being in the gym on Tuesdays and Thursdays when I'm always there. And if I'm ever gone, the one person I have trained is who is there. And so we do everyone's intake one-on-one. We do at least their first exercise day one-on-one, and any additional to kind of help them be more comfortable. We built our paperwork to follow them very strictly using RPE and heart rate. And then as people need, one-on-one help, whether it's, setting machines, getting on and off the treadmill, we can kind of be there, but also work with multiple people at once if needed. And we do have other staff in the gym while I'm there if I, needed assistance with any of our patients. So that's kind of our outpatient model. We did also start an inpatient model of care, which has been amazing. So we get referrals from our hospitalists and oncologists over on our oncology specific floor. Typically over there, we're seeing patients that are either inpatient for chemo, or they're in the hospital maybe for their cancer related surgery, or they're having side effects of their treatment and needed to be hospitalized. So we cover that floor 5 days a week, which is really great. Funding. So we are kind of funded by the cardiac rehab, but we're also kind of funded in the fact that we're a phase 3 model. So each of our patients, if they have an insurance reimbursed program like a Silver Sneakers or Silver and Fit, we are a facility that can take those incentives. Or we do have a small membership fee. So our membership fee is $25 a month. And it, again, similar sliding scale, scholarships, things like that, if that's a financial burden for everyone. But that's been really helpful. And it's nice. We even started for the cardiac program, but if a support person wants to come exercise with our patient, because it's a gym space, they get a 50% membership discount. And so then they can also come and exercise, any of our patients have that, which has been really nice too. But I would love to have more funding and more staff. So that's a goal for one day.
I love that you have that incentive for the support. That's so important, as we know, for people who are going through a cancer diagnosis. Karen, why don't we hear from you next?
Okay, so I started Maple Tree back in 2011. So it'll be 15 years next year. And essentially, we're very similar to the others in that we follow the phase model. So we work with anyone from the time of diagnosis through cancer survivorship. We have 103 different partnerships and locations around the world. And so depending on the setting and who the particular partner is, it might look a little bit different. And so primarily for our clinical settings, we are just working with patients who are in active cancer treatment. And that is all individualized exercise training. And we follow the model with the, fitness assessments and individualized exercise prescription. And we meet with them once a week for their exercise programs. Most of the time that program will last 12 weeks. We do have some clinical partners that will allow patients to stay in longer. But again, that's usually dependent upon funding and then just our availability, our space within that site. And so, it looks a little bit different as you go from one site to the next. I would say about a third of our locations, of our clinical locations, are in person, and then probably 2/3 we see people virtually. Primarily that is in very urban areas like New York City, where it's very expensive to hire trainers. I can run my program and staff my people here in Dayton, Ohio, which is about a third of the cost of living that it is in New York. And then for patients, it provides, they don't have to worry about transportation into the city. So that definitely helps remove that barrier. And we also have a lot of our rural areas. We see people virtually as well. Something that we just started rolling out over the summer is an app which all of our patients can access for free. And within the app, we have a library of videos that we have filmed that are kind of curated according to tumor type and side effect. And the way that we utilize these videos with our active patients, the patients that are currently meeting with us, is we will, meet with them once a week, but then on the other days, we assign them videos from this library. And that helps to keep them engaged during the week. So say I meet with you Monday, we do our session one-on-one, then I'm going to give you an exercise video to do Wednesday and then, Friday, for example. And on our end, we can track, did they do the video? What was their intensity? Any feedback that they have? And then patients have the option to then, once their time with us comes to an end, they can subscribe to those videos and have access to the whole library. Since we've started doing that, we have seen our functional scores in the patients that are doing that improve by about 27%. So we've seen, we're very happy with that increase. And definitely, I think it helps just improve engagement throughout the week. So that's been something that's been really good. We also have some community partnerships, and primarily in the communities, we license our program. So I'm not staffing those models, but we'll go in, and I have a certification that I developed a while ago, back in 2013. And I used it internally initially to train and onboard my staff. But since 2019, we've been using it commercially as well. So that's the Exercise Oncology Instructor Certification. So we have that certification, and we also have a Cancer Fit certification that we partner with Livestrong on. So depending on the credentials of the fitness center employees, if they have a bachelor's degree, they can sit for the EOI certification. If not, they can sit for the Cancer Fit certification. And then we also offer a license to community-based fitness centers or medical-based fitness centers to license our program and to start their own exercise oncology program. For that, we do limit it to people who've completed active cancer treatment. So primarily, it'll be, they're in remission, long-term follow-up care. That's going to be that main audience. And with that, we do have program templates for people who want to do the one-on-one training, but then we also have group class templates as well. And in our clinical settings, we don't typically do group classes. They're all individualized. So that's something that we would offer more when people have completed active treatment. So those are the two primary programs that we have. And then internationally, we do a lot to certify and train people and then help other countries to start programs, because you have some countries where a lot of people are doing this and they just need the training and the certification. And then you have other countries where it's like one person who wants to start exercise oncology. So it differs a lot. And then in terms of funding, we are a nonprofit as well. We don't charge our patients for our services. So primarily the funding comes from the hospitals we partner with, either the overhead of the hospital. We'll get funding for a certain number of patients or a certain number of appointments. So either the overhead of the hospital or the hospital-based foundation. Or, I write a lot of community-based grants. I did get a big national grant this year. It was the largest grant that we've received so far. But I'm excited about that because I think that will help open doors for more opportunities like that, because right now I write about 50 grants a year just to piece together funding, whether it's $5,000 here, $2,000 there. It's a lot of grants like that. And then the last thing that I'll say regarding funding, as of next year in Nevada, there is a Medicaid payer called CareSource, and they are going to be covering Mapletree services for their in-network patients. And so that is a brand new thing for us. We're really excited about that. We're figuring out now what that funding mechanism looks like, with us being exercise professionals. How are we going to bill? What codes are we going to use? All of that. But I'm very optimistic that will lead to more funding opportunities, not only for Mapletree, but just for the field of exercise oncology.
Great, thank you, Karen. And just because this question relates directly to what you were just speaking about, I am going to ask this question and then we'll move on to you, Ashley, if that's okay. Just a viewer was wondering if you could expand on the videos in your apps. So they're just wondering what types of videos that you're showing, and you did say, I believe, but to clarify, they're self-developed through your program, correct?
Yes. So we call it Mapletree on Demand. I got the idea from Beachbody, and I have the Beachbody app on my TV. So essentially, the idea is their entire workouts. So I can follow along in my home. I don't need any exercise equipment, and they vary in terms of intensity level. So we have low, moderate, high intensity. So the trainer will select it according to the ability level of the patient. But we categorize them according to tumor type and then according to side effect. And so, for example, if you look at our breast cancer library, you have the general breast cancer library, and then we get specific with, okay, upper body range of motion. That's like a 6-week series that we have. We have a lymphedema prevention, I think 3-week series. We have one for prehab, and so they're all varying lengths. That kind of relate to the typical side effects that you would see with that particular tumor type. So, GI cancers, we focus a lot on core. And then we have some general ones like fatigue fighters, and, that's a 12-week that anyone can do. And so there's about 250 total videos within the library right now. And that's something that we're looking to expand on next year, just because we have had such a good response to that. And then we do make that available as part of our license for fitness centers. So anytime we partner with a medical fitness center or a community-based fitness center, they have the opportunity to use those as well.
Fantastic. Thank you so much for clarifying that. That was great. All right, Ashley, we'd love to hear from you next. Last but not least.
All right. So my program is a little newer. I think it's been running for a little under 2 years now. Originally, it started as completely in-person supervised exercise, where, again, it started with survivorship. We do an initial assessment and then a reassessment. I still do that, but since then I have expanded to seeing more high-risk patients in person. So that's going to be during treatment, chemo, radiation, or if they're severely deconditioned, fall risk, so on, so forth. but it has kind of transitioned into getting them to exercise independently. So I'll start with an initial assessment, and then from that, I'll be able to give them a home exercise plan. Usually I'll see people 3 to 4 weeks so that they can understand form, understand how to progress themselves, and build from that foundation. And then every 3 to 6 months, depending on the availability of the patient, we'll do a reassessment to track their progress. I still follow the UNCCRI phase program to the best of my ability. Dependent on the patient, we will always do based on RPE, or if they have some way to track heart rate, I can do heart rate reserve and that. Additionally, if they are far from treatment, so they're just looking for guidance, I'm exploring the virtual field. So still everyone will start in person with an initial assessment. They're always eligible to a reassessment so we can track that progress. But especially with Chicago, access to the hospital can be challenging for a lot of patients. They have to pay for parking and everything. So a lot of them just like having that exercise plan, take it home. They know how many minutes they should be walking or cycling. And I try to keep it individualized based on the equipment I know they have access to, whether that's at a community health center or if they just have some equipment at home. And what else? Currently trying to explore more of the prehab field. So looking for opportunities with that. For funding, I started as a part-time contractor role. After about a year, the hospital saw that there was value to it and they have taken it on as a full-time role. It's completely free service to our patients. And what else? Did I cover everything? Am I missing anything?
I don't think so. No, that was great. I think though, kind of in line with where you just left off, right? Talking about this funding, and each of you have slightly unique situations, but we have a great question that came in that I feel like is related to where you ended there, Ashley. So the question is, it sounds like insurance does not recognize these programs, even though they are very similar to cardiac rehab. Is there an effort to demonstrate the efficacy and benefits to get insurance to buy in? So I don't know if any of you would like to take that. Karen, you want to? Go ahead.
I can speak to that because that's an initiative that we've been working on since 2018. So yes, there is a lot of work going on trying to, advocate for this. So it looks like the path is we need to, we were successfully able to make breast cancer this part of standard of care for breast cancer patients, which kind of opened the door for more serious conversations with CMS. We were invited about a year, probably 2 years ago now, to submit a national coverage determination application asking for insurance reimbursement. We went through one round of revisions with CMS, and we're scheduled to have, we submitted the revised draft last year, had more than 20 professional organizations write letters of support. We were very optimistic that it was going to be successful. Our meeting with CMS, the follow-up meeting, was scheduled for, I think, January 23rd. So right after the new administration took over, and the people we were working with at CMS are no longer there. And so we basically had to start from ground zero with them. It's looking like, though, there is a door open with a more universal coverage, potentially under the fall risk category. People with cancer are, I think, 17 times more likely to fall than someone without cancer because of the peripheral neuropathy and the balance issues that happen. And so if we can demonstrate reductions in falls, then that can potentially lead to a funding mechanism. So I know that is the path, I think, that we're going down right now with CMS, and it sounded like they were wanting to have a more aggressive timeline in terms of pilot studies and getting this out the door funded here within the next couple of years, but things always take longer than what you think. So meanwhile, we're also working to try to get a quality improvement study with the Commission on Cancer, which would be another path forward to getting exercise part of standard of care for all tumor types, not just breast cancer. And when you have that, that's the medical necessity that you need that then would open the door for funding. And so that's the work that we have done. I know locally with the CareSource organization, they're local to Ohio. I don't know why Nevada popped up as the place to trial this, but I do have the interest of CareSource in Ohio as well. And so I do think we're seeing a lot more interest and a lot more engagement from payers. So I'm optimistic. I think by the end of this decade, we will have a clear funding mechanism in place. That's my goal. That's my goal. So we'll see.
Thank you. That was very informative. I appreciate that, Karen. I hope so too. All right. So moving now into, again, more of these, we have some questions that are coming in. So these are good. So I think I'm just going to kind of take them and read them, and I'll try to direct them as I'm able to. But again, if you really want to answer one, feel free to raise your hand. So this is about inpatient rehab. So the question is, do you do inpatient rehab while patients are admitted? And it said then sometimes patients are admitted for treatment. And then a follow-up to that, and so maybe this was in relation to what you were discussing, Sadie. Secondly, do you have an active space for patients in the outpatient setting, maybe a leg cycle during infusion for 10 to 20 minutes? I used to do this for my patients. Inpatient, they would either walk during infusion or just before, and I saw a huge decrease in symptoms, side effects for treatments, and an increase in endurance and strength.
Yeah, so prior to us even being over on the floor, they had a recumbent bike. So that was the one option. However, there is one recumbent bike shared on a unit of 20 beds. And so that was one option. Or physical therapy, works on that floor, especially as we know some patients need to go to like inpatient rehab or skilled nursing after. Really, this whole came from they had functional patients who came into the hospital to get their typically chemotherapy prior to a bone marrow transplant. And these people would become less functional during their treatment to the point where then like PT would have to see them. And it's like, well, why couldn't we intervene when they were functional to avoid that decline? But PT can't necessarily see patients if they're at their functional baseline. So we saw that there's kind of this challenge within the healthcare system. And so we are kind of filling that space. So we are able to see any patients on that floor. Sometimes I'll even co-treat with physical therapy if the person is a 2-time assist, which is really great. We started bringing over resistance bands as an option. So having that as an additional modality for our patients. We'll walk patients in the hallway. We do exercise in their room. It's kind of whatever fits the patient's needs, wants, goals, and what we're able to do. We are really hoping I have identified a space that's right by our oncology floor that we're hoping to build into like a mini gym. And so it'd be locked like behind doors that we could then take patients there one at a time and make sure that it was clean. And the goal would be that we would have a new step, a crank machine, and then some dumbbells and things like that. So we're kind of building it as we go. But we've had huge success, I think, from like the patient perspective, and they've loved it, and our providers have been really happy. And really it was just like asking like, how can we help? And we're integrated within EMR, so that's been nice that we get epic orders for inpatient care.
Great, thank you, Sadie. And I feel like you alluded to some of this, but this leads well into this next question. Just asking in general, what other interactions your programs have with cancer rehab, physical therapists and occupational therapists. So I don't know, if Ashley or Michael, if you have anything to add at this point to this, just because we haven't heard from you guys in a little bit.
Yeah, of course, I can jump in here. So we, in previous years would have a strong rapport referral system through community-based, outpatient, or hospital-based therapy services. Currently, right now, we have physical therapy in our facility. It's not all 5 days a week. We have it right now 2 to 3 days a week, depending on the scheduling of the patients. And how that works is that it's either sistered up or right next to the hours of our intervention. So if we see a patient 9 a.m. Monday, Wednesday, Friday, the therapist would typically see them at 8 a.m. or 11 a.m. like before or after their sessions, depending on what they need. This is really unique, and I think it really completes our clinic because that scope and practice of for our physical therapists is going to be neuro board certified, oncology board certified, and really working on more of those scopes and practices, as in like post-op, pre-op, tissue management. She's also a CLT, so any lymphedema concerns that we may have, and it works through a reversal referring. So some patients that are severely deconditioned and may not be, completely ready to start an exercise intervention at our level or capacity, even though we're at low intensities, we'd have them see our therapist and then they can refer to us. Or if we have a patient with intake and we notice some things through our physiological initial assessment, we will also refer to her as well. And that's something that, for the course I teach, we're going out to teach and educate what we do through just cancer rehab, our model, that phase perspective, through PTs, OTs, SLPs, EPs, and CEPs as well. So this is something where it's really important to have that continuing education and knowledge base, and also have a collaboration. A lot of the issues that we come and see is that, like Sadie was talking about, there's certain points in times that physical therapists, especially if you're in acute care or inpatient or even outpatient, you're not going to be able to see those patients. And if you're able to, then there's only allocated so many visits you can do that. So it's really important that we work on this collaborative effort as now. And hopefully, Karen, thank you for all the hard work and everything we're doing to hopefully get this billed through insurance. But, as of right now, we need to collaborate and kind of use one another to really help these patients that, it's not a want, it's a need.
That's great. Thank you. Ashley, did you want to add anything, or saw you nodding?
Sure. Yeah. For inpatient, at my hospital, at least, mostly all physical therapy handles that. Similar to Sadie, though, I do get a lot of patients that are either going to physical therapy and seeing me so that we can work on that baseline strength, or they have completed physical therapy and sure they're at baseline, but they're still severely deconditioned. It's nice that I am able to see anybody, since this is a free program to all rush patients. I see them, we work on strength conditioning, and then we see the improvement from there. A lot of the times too, if for some reason they aren't able to increase their strength, I have had that connection with their care team where I can say maybe this person should benefit from another round of physical therapy. So it is, again, a collaborative effort to help the patient from their baseline and further. So.
That's great. I feel like a theme that has been kind of strung throughout this is the topic of access, right? And so accessibility to patients, and obviously working to make it more accessible. So this is a question kind of in a similar light in terms of just accessibility and who these programs are appropriate for. So they've been kind of discussed a little bit more generally, but this individual is asking if your programs are catered to a wide age spectrum of oncology patients, including pediatrics, school-age children, adolescents, and kind of that 6 to 18 area as well. So, Karen, do you want to? You're nodding, so.
We're actually waiting on a grant to see if we can expand our pediatric program. But yes, so we serve all ages, all stages of cancer. I will say, 103 locations, 2 of them are pediatric sites. And so it is much harder, at least for us. We found it to be more difficult to kind of break into that arena. And if you look at the literature, you know what, we have 31,000 published articles on adults with cancer and exercise. And the last time I checked, which was a couple weeks ago, we have 168 articles on pediatrics with cancer and exercise. And so I think there is a huge gap there, and something that really does need to be addressed, especially when you look at the long-term effects of a child going through cancer treatment. And so that's definitely something that is a priority of ours, is to, you know, try to work more with pediatric cases. Now, I will say, I think the implementation of such a program is going to look a little different than it does in the adult population, just because their treatment is longer, you know, multiple years, and you're dealing with, you know, all different age groups. So like a 3-year-old, it already has high energy. And so building fun and games and making it interactive into the program is good. You know, that program is going to look a lot different than a 65-year-old overweight woman with diabetes, you know, so they're very different programs and a very different approach, but something that I think is a huge need in our field.
Yeah, wow, thank you. That I did not know that statistic, so that was informative. Just because we have a ton of questions coming in here, so I'm kind of bouncing around here, but this one's related to cancer research, so I'm just going to read it directly. I'm currently working in a cancer research center where I see both the strengths and gaps in how exercise is integrated across clinical and research settings. From your perspective, what are the most critical research gaps in exercise oncology right now, and how can early career researchers like me position ourselves to address them through PhD training? So that was a couple of questions, but Michael, you talked about education and research with your program.
Yeah, I was going to hop in.
Know.
I didn't know if Karen wanted to grab this one as well, or please.
I'm trying not to monopolize the conversation, but I can go after you.
No, that's fine. I can speak on our behalf, and then obviously with the more experience and time out there and working with your PhDs. You know, for us, I think, I guess, just to reiterate or confirm the questions, some of the gaps, is that the core of that question, Taylor?
I'm sorry, can you repeat? I was reading the next question. So.
Oh, no, you're fine. So yeah, so I just want to confirm that some of the gaps or some of the issues or some of the struggles with that initial research at the core of that question.
Yes, so it looks like gaps when it comes to integration across the clinical and research settings. So
I can tackle that. Yes, I think the big thing is continuity. I think we can all agree, and we all come from a similar tree, at least from UNCCRI in that perspective. But, you know, as I've educated and taught more and more, and as we, you know, our call to action is that we would like more quality research, but using the tools and making sure that these are reliable and valid and repeatable measures. So for us, I've seen different studies as it just looks at aerobic intervention just for resistance intervention, or a combination of both, or length and time, or only patients in treatment. For us at our facility, you know, we are not allowed, so we go 18 and older, but I've had an 18-year-old and I've had a 96-year-old. So we do have a wide variety of different ages in that component, as well as all diagnosis. You know, even if it's just diagnosed and before treated, current treatment, post-treatment, years after treatment as well. But yeah, so the reliability in using those tools. So for us, we utilize a treadmill protocol with a submaximal test. Right now, we're in the process of revalidating that through a portable med cart as well, utilizing strength components and making sure that, you know, when we're looking and correlating this information, as we look at the normative data, how are we classifying these individuals? So again, that continuity is where we all have to come together and have an understanding or a goal in action. And not saying how we do it is, you know, the only way. You can do it many different ways. As Karen said, different facilities, different resources. I think you need to implement and provide service to the best your ability at that time. But for us is having that continuity in collaboration with the research and making sure what we're looking at is something repeatable. And, you know, for us, we do a 12-week intervention, and we're making sure that everyone that goes through our program, we're trying to ensure, somewhat like what Ashley was doing every so many weeks interacting with the patient. For us, we have a little bit more control of that one-on-one supervised perspective of, you know, at every 4 weeks, we're ensuring that the progression and the overload, and it's individualized. So following those principles as well as we have those patients to graduate to the next phase. So I feel like wherever you're at in, you know, your studies, just making sure is what you're looking at and researching and developing the program. I think that's a necessity, and really the goal is making sure that you have some good, valid, you know, parameters that you're looking at. It's repeatable, and it's something that's reliable as well.
Can I add one thing to that too?
Yeah.
Just something that I've heard come up many times in conversations as we, you know, look to making this standard of care and hopefully one day getting insurance reimbursement, is just the triage and referral. And, you know, I mean, we kind of touched on it a little bit with physical therapy. So triaging patients and seeing who needs physical therapy, who needs exercise. But then beyond that, I think quantifying the sessions that they need. Does everyone need 12 sessions? Is there just as much benefit if they get six sessions? And if not, like being able to articulate that and to justify why we need 12 visits. I think being able to answer all those questions is going to be really crucial, because once this is standard of care, once this is reimbursed, we're looking at 2 million people being diagnosed every year. And so we need to have these pathways for these patients to go. It can't be a one size fits all. So we have to be able to justify why some people need PT, why some people need 12 sessions, and why some people need 4. So if you're an early career researcher, I would definitely look into those different things. And then I would just say as well, looking into implementation in minority populations. What does that look like compared to rural settings, compared to urban settings, and being able to kind of spell out what our best practices, so that more people can start programs and kind of look to the success of other programs and other articles that have been written, so that they can adopt those for their own programs.
Yeah, no, it sounds like a lot of good work that can be done coming up here. That's great. Okay, well, thank you. So moving into our next question, this is looking a little bit more at acute care. So I'm going to target Sadie and Ashley on this one. Is there a specified time frame you do not work with a patient after receiving chemo? And then this individual said, as a general rule, I used to wait 48 hours and reintroduce light movement at that point. Is there a defined time frame or one that you have found is best? So Ashley, I think it might be interesting because you talked about how you really worked with high risk patients there for a little while. So maybe we can get kind of two different perspectives on this, maybe a high risk versus a normal risk.
Yeah. Off the bat, I mean, I don't have a strict restriction time from when they have received chemo. A lot of the times it's going to be depending on the patient. A lot of the patients that I see, they say the first 3-4 days after chemo, they're completely wiped out. So I encourage them when they're home, they're not doing much, the least they can do some light movement. Again, I give them some sort of home exercise plan. I tell them based on how you're feeling, follow that RPE scale, do something light, move, try your best. If not, we'll pick up the next week. I've also seen that a lot of patients like coming to see me right before their treatment, so that they know that this next week they're going to be laying around, maybe doing minimal movement. Let's get this in while they're feeling good. And then again, repeat that with their chemo cycle.
Yeah, I would say I have a similar experience as Ashley. I would never restrict it. Like if someone felt good, again, I would say I've had patients where they feel really, really good the next day, and then I know that 2 days later they're not going to feel so great. So definitely not doing their full intensity of their prescription if they felt like coming in the next day. And as crazy as it is, but just how different people respond to treatments and the different treatments they're on. this is why it's so important to have like tools in place for assessing how that person feels, because you might see like changes in their heart rate, changes in their blood pressure, making sure that you're asking them about the different symptoms that they may be experiencing that day. What is their RPE? Every time people come in on their sheet, they're rating their pain and their energy level for me. So I think having the appropriate measures in place for kind of that assessment every day, and that could be treatment or not. And then I would say I similarly have people that also like they want to get it in. Like if they got treatment on Tuesday, they come on Monday, and then they might say, you know, maybe we'll see on Friday. And again, I would modify that prescription for that Friday if they felt well enough to come. This isn't part of the question, but one that I think is important for on treatment. When I have people that get radiation, if they feel well enough, they come 5 days a week to exercise with us in the gym, which they're like, I'm at the hospital anyway. Like I want to do something. And I think that it helps them feel empowered. And honestly, a lot of them have had decreased fatigue values from coming and doing something afterward. So what we did is we built alternating days of their exercise session. So they have an A day and a B day. So they don't exercise like as long as someone that maybe comes, you know, only 2 or 3 times a week. But we alternate what machines they're on. We alternate like what aerobic exercise they do. So that was really fun to create because I've never had the opportunity to work with someone 5 days a week before like that.
That's fantastic. I think coming off of that, we had developed a couple of questions prior to, you know, organizing and figuring out what we wanted this panel to bring. But I feel like, Sadie, that actually leads us really nicely into one of those questions. So I feel like you touched on this a little bit, but I'd be curious to hear from all of you just what some key ingredients are to make your program successful. And maybe beyond that too, you know, what is the impact that you're seeing when it comes to your patients and the clients that you're working with? So why don't we start? Let's start with Michael.
I didn't want to jump in right away either. So yeah, so what are some of the key ingredients? You know, for us, we are very fortunate in how we structured our program. And I think one of the huge key ingredients is that we individualize every exercise prescription to each patient. We cater it to treatment status, how they're affected by side effects, but, you know, not only just a demographic, a diagnosis, and a treatment, we also look at the patient as a whole picture. You know, is there any other comorbidities, any other disease concerns, any other things that we need to be cognizant or concerned with, and also just educating the patient. So really individualizing each one of our prescriptions for our patients, and then that one-on-one supervised perspective. And as I mentioned, I know that's not, you know, can't be done everywhere, but for us, it's something where we maximize that benefit for rehab for all of our patients. And then for us also is education. As they go through that phase model, we really try to not only educate ourselves, but also have the patients really understand and build that self-efficacy, right? That confidence of how do I exercise? How do I do this? And we work, you know, anywhere from if they're going back to a wellness center, the YMCA, you know, a gym, or just home equipment, right? I always tell everyone as they progress and adapt a healthier lifestyle, this doesn't mean they have to go run on a treadmill and lift weights. Obviously, those are a little bit more objective for us to measure, but we also need to look at the goals and motivations of the patient. Here in Colorado, since most of the panel has been out here, we have a lot of, you know, even if an older individual is active, they want to get back to hiking or going up in the mountains or doing activities with their children or their grandchildren. So these are all things that we try to incorporate and most importantly, individualize to each patient.
Great, thank you. That was awesome. Ashley, why don't we hear from you next?
Yeah, I think for me, it would be really meeting the patient where they're at. I think I'm in quite the opposite realm of Colorado. There's not much physical activity, and I say meet the patient where they're at because while I want them to go do resistance training, I want them to walk, a lot of these patients that I've seen have never been exercisers. This is maybe the first time that they're starting to exercise, and along with the diagnosis and getting over the side effects. So it's been a learning curve for me too, but we have to realize that a lot of these people are starting new lifestyles. So maybe they're not following the exercise prescription 100%, see what they have done and really reinforce that. Really, any exercise is going to be good for someone that hasn't exercised in the past. So reinforcing the good habits and then seeing how we can build off of that has been where my program has been successful. They start to feel happy, and then eventually these people see the benefit of the exercise. They say, I get the energy. I don't like when I'm not sitting. So that's really the goal for a lot of my patients. So yeah, meet them where they're at.
Yeah, that's great. Emphasizing, like you guys have all been saying, it's really dependent on the individual. So that's fantastic. Sadie, why don't we hear from you a little bit more? Again, I feel like you kind of started down this route, or down this path. So
Yeah, I mean, to both their points, it's individualization. So coming in and like building the program from scratch, I kind of felt like I brought different pieces from my different experiences, and I hope we get to continue to grow. So I have kind of the UNC aspect of using that programming and assessment model. I hope to eventually get to add a consultation type of model like what I did in Kansas City, so that I can meet with people in our infusion and radiation spaces. One, to educate them on the importance of exercise and talk to them about where they're at. That would be a referral then to our outpatient space to get people into the gym, or to get them to a community center. So I think that's great. Being in the hospital system, I think having the inpatient component, I hope that we eventually can work to really get some of those inpatient patients to outpatient patients. It's hard to sometimes make that transition, especially knowing how sick some of them are. But I think we're kind of moving in that direction. It's amazing that we're integrated with our hospital's EMR. That was a huge, I mean, I have our Epic system, but I recently got access to our Oncology EMR, because not every patient comes in and knows, which treatment they had or how many treatments they have. So we've had a couple pieces of success that way. And then in terms of like the impact, I think those things where you're getting people back to what they want to do and making sure that, we're meeting their goals is important. But one piece I always like to really educate providers and patients on is sometimes success does not look like an upward trend. Sometimes it's the lack of a downward trend, or like that maintenance is a win. And I think that's been a huge thing in our space, with just seeing so many more diagnosis types. And we take anyone from diagnosis through whatever survivorship or advanced cancer they're going through. So redefining success, I think, is really important.
that's great. Thank you. And then we'll end with Karen. I think you'll bring us to the end of our time here. So what are the key aspects that make your program successful, and what is the impact that it has on your?
Yeah, I mean, just like everyone here, I think the evidence-based, meeting patients where they are, individualizing the programs, making sure that, you're hitting the mark on all of that. Another key initiative of Maple Tree is really in terms of service. And so, not only focusing on, sets and repetitions and what exercises are we doing, but also just serving them well, and making sure that we're creating a welcoming environment for them, and engaging in developing those relationships with the patients, because we have seen, as we develop those relationships, and they're more likely to come back, they're more likely to trust their trainer, and try something new, and maybe they might not have done that before. And then that helps with satisfaction scores. So then they're going back and they're talking to their oncologist, and then their oncologists are going to refer more. And so that is something that we have really spent a lot of time focusing on, is how are we serving people, and really trying to serve them with excellence, and creating a warm and welcoming environment for them. And then in terms of outcomes, so we look at quality of life, we look at function, and making sure that we're measuring all of that. A newer thing that we're starting to look at more, just based on conversations we've had with CMS, is fall risk assessment, and even tracking falls with patients who are with us, and tracking them, for about a year beyond their time with us, just so, when the time comes, we'll have data to show that we can hopefully we can show that we can reduce falls. And then we've also done a lot of work looking at healthcare utilization and just basic cost of, are they going to the emergency room, and if they are getting admitted, how long are they being admitted for? How many encounters do they have? And again, all of that data is really to help support the potential of down the road having insurance reimbursement and really being able to make a case that, this is a program that is going to keep your patients healthier in the long run. They are going to have lower healthcare utilization, and so you can save money on these patients down the road. So those are just the things that we do that, weren't mentioned, but I know, I think we all kind of feel the same way, like making sure we're serving patients well and safe and effective programs.
Fantastic. Thank you guys so much. Well, we are at the end of our time here. I know I learned a lot. I feel like we could have 5 more of these and we'd still just be hitting the tip of the iceberg. So thank you to our panelists, and then also thank you to our attendees. Just a reminder that you will have access to the recording 3 months, or for a total of 3 months, and we'll get that turned around to you guys as soon as possible. So again, on behalf of CEPA and our Continuing Education Committee, thank you for joining us tonight. And I hope everyone has a great evening.